Well, I'm going to talk about the last topic, which is just very brief, so that we keep an eye out that these patients can develop renal tubular acidosis as a complication. What is it about? It is a metabolic disorder caused by a tubular dysfunction, which results from an inability or failure to eliminate hydrogen ions or to reabsorb bicarbonate, and as a consequence, ultimately leads to metabolic acidosis with a normal anion gap, such as it has an incidence of around 5%, and the pathophysiology is quite varied, involving autoimmune complexes, secretion of inflammatory mediators, and the most common type is type 1 renal tubular acidosis, which is the distal form. It presents with clinical manifestations that can go unnoticed, very silent, which is why we need to perform regular screening in these patients. How do we do that? Well, depending on the clinical presentation, we need to monitor for the appearance of edema, nephrotic nephritic syndrome, polyuria, and also through the lab tests we routinely request. We need to examine the urine sediment, blood tests, check serum, creatinine, kidney function, and electrolytes. And what factors are associated with renal involvement in these patients? Those patients with SRE syndrome, who are of advanced age, who develop cutaneous vasculitis, who have a high SDAI, who are seropositive, and who present with hypergammaglobulinemia or hypocomplementemia. So when should we suspect it and how do we diagnose it? Well, we should suspect it in all those patients who present with urinary manifestations such as polyuria or polydipsia, since they have an inability to concentrate urine and who have an elevated urinary pH greater than 5.5. We should ask if they have ever had a renal colic, since that can point us toward this diagnosis, because they have hypercalciuria and alkalinization of the urine, which promotes the precipitation of calcium phosphate salts. They can also develop nephrocalcinosis. We also need to check for electrolyte imbalances, as they may have hypocalcemia, and as a result, they can develop spontaneous fractures, muscle weakness, cramps, hyponatremia, hypokalemia, and hyperchloremia. So in lab tests, these patients will primarily show a metabolic acidosis with a normal anion gap and an elevated urine pH greater than 5.5. We can also order an abdominal radiograph, which is readily available, and there we may observe lithiasis or nephrocalcinosis, as I mentioned earlier. For instance, an abdominal radiograph can provide additional insights. It's also important to highlight that renal tubular acidosis, as my colleague Carmen rightly mentioned, scores points. In the renal category of the SDI, with 3 points if there is impaired kidney function, and 6 points if it is associated with acute kidney failure or accompanying proteinuria. How do we treat it? Our main goal is to improve and slow down the progression of kidney disease, focusing primarily on symptomatic treatment by correcting the acidosis with oral supplementation, bicarbonate, and/or potassium if there are associated electrolyte imbalances. Immunosuppressive drugs such as high-dose glucocorticoids or mycophenolate are used, and it's important to keep in mind that if these patients have already developed fibrosis, the damage is irreversible. Even so, the prognosis is usually good and they have a low incidence of developing kidney failure, and they also tend to have a high morbidity.